Thank you. My name is Anita Prentice. I'm the president of the board of the Desmond-Fish Public Library, and I'd love to welcome you all here today. This is one building block in a program that started over 2 decades ago. And I'm very honored to say that our former board member and advisory council member, Steve Kent here, was present at the creation of the idea of the library dedicating program time on Martin Luther King Jr. Day weekend to bringing the dream home, to talking about the ideas of Dr. King, asking what we can do as individuals and as a library and as a community to help keep this dream alive and share that dream. So I would like to, the programs for all those years have been supported by our organization called the Friends of the Desmond-Fish Library. And it's my honor to introduce Carol O'Reilly, former president and current vice president of the Friends of the Desmond-Fish Library.
Hey, Carol.
I also wear many hats in this community. And I do work part-time at the Hastings Center. And for those of you who are not familiar with the Hastings Center, we are a bioethics research center right down the street on 9D. Dr. Brown started with us in September at the Hastings Center. She is our newest research scholar, and her specialty is in health equity and U.S. population health.
Can you explain it?
And just wanted to say thank you very much for your time and energy and doing this program.
Thank you, Carol. I guess it's my turn?
Yes.
Hello, everybody. Thank you so much for coming out. As Carol said, I'm Virginia Brown, and Virginia A. Brown just makes it a little more, different. It's a pretty straightforward name. I wanted to first start by thanking the folks who made today possible. It starts with Carol, who asked me early on, shortly after I arrived at the center, would I do this? And I was like, sure, right after the grant gets written, and the day before I go to Texas, of course, I have an idea. So I thank you and Anita and Dana and Justice for the opportunity to come and talk to you. As you may know a little bit about me, I arrived from the University of Texas at Austin in August and joined the Hastings Center in September. So if I use the word y'all, it's just because, Texas gave me something very valuable, a way to be very inclusive with my language. All y'all means all y'all. So let me introduce that term to you. May you take it into your canon and invite everybody in. So if you hear that, that's kind of where that came from. I have some very prepared remarks because I think it's really important when sharing what for me is it's not a new idea, but this is one of the first times publicly that I'm sharing with you something I've been thinking about. So I have scripted some things that I want to say very specifically to you. And maybe we'll be here for like 10, 12 minutes if I don't talk too fast. And if I'm not talking loud enough or too fast, just sort of wave at me and I can adjust. I want you to feel like this is a graduate seminar, but there was no requirement, there was no pre-reading, there is no grade, everything's the right question, there is no judgment. So we really want to spend most of our time together in conversation. I'm going to share with you some ideas, but wherever you wish to take the conversation, I will do my best to respond and let's interact as a group. So let me see where I am, alrighty. Again, let me start by thanking everybody. And could you advance to the next slide? It's going to do one thing. Let me stop here. The talk was publicized as what you saw before, and often as a scholar or a writer, your editors will ask you to make some adjustments. And I'm like, sure, anything for publication to make it more accessible. But this is really what I wanted to say and what I'm going to talk about. When we talk about injustice in healthcare, in health and its relationship to physical health, and getting King's words right, which I borrowed from another scholar and we'll talk about Charlene's work later in my discussion. but I wanted to know injustice in health and its relationship to physical death, getting King's words right. Next slide. So why are we here? I know why I'm here. I know what my charge was, but why are y'all here today? You came because you
We wanted to meet you, Virginia.
Oh, okay, thank you. All right, I wanted to meet you. You came because you wanted to learn or know or hear about something or meet folks, some folks from the Hastings Center? And anything else? Any other idea? Yes?
I mean, the big overarching idea of the program was to come to terms with, it's racism, it's segregation, it's a huge legacy to try to face that and build a inclusive.
Did you have a preview of what I wrote? Because that's what I wanted to do. I wanted to make this more than a performative MLK day, right? I wanted to not talk about the letter from the Birmingham jail. I wanted to talk about King's work in particular and connect him to health and well-being, because that's the place where my work comes from. That's the bioethics work. I'm here in part as a citizen, a member of the community. I also do come from the Hastings Center, but the words that I say are my own and not necessarily a reflection of the center. But I am a bioethicist. So thinking about King's work and thinking about the intersection with where we are in this world today was really critically important for me to find and to share with you. So that's why I'm here. Thank you for that further insight. And what I'm going to start with is a little poem. Some of you may have seen this, but it's a work from Mary Pfeiffer. It's an inspiration from Mary Pfeiffer. Some of you may know her work. Saving Our Adolescent Daughters, Reviving the Souls of Ophelia, or Writing to Save the World. I think she's a phenomenal writer, and she wrote this wonderful book, and there was a prompt in her book that I've used for more than a decade. I've used it personally. I've assigned it in my classrooms. And it's designed to answer the question, so tell me something about yourself. And in trying to do that, it's called The Story of Who I Am from. I'm from the product of this country, the great-granddaughter of Hilliard Alexander, whose father owned him. I am from Aaron and his brother Steve and Marcel, black men, my great-grandfather who practiced law and his brother who practiced medicine in the decades at the close of the 19th century. I'm from Mary Elizabeth, the daughter of Raymond and Sadie, who began practicing law 100 years ago and whose work set out to desegregate Philadelphia and beyond, shaping the foundation of the legal architecture that would become the framework for the civil rights movement of the 1960s. I'm from Nell, whose mother finished 6th grade, but whose father labored in the coal mines of Pennsylvania, and at times was paid in script. I am the daughter of an Air Force fighter pilot. That's Colonel Brown to you, and to that he would add, great boys in this here man's army. He was a man who flew 100 missions over North Vietnam. I am a mother whose offspring sought a life in the concrete jungle where dreams are made of, and they're making their dreams come true every day in the city that never sleeps. I'm from an exceedingly complex family structure, one that valued education and self-determination above, well, almost everything. I'm from a land called Texas, a town north of Dallas, my parents having done reverse migration, moving from the east to the south, to the Golden State, and back to the east, and me back to the south, and now back to the east, and I think I'm finally home. I'm from sociology, and I bring you the sociological imagination. That imagination lets me recognize and respond to social problems as public issues rather than personal troubles. This lens focuses on the social patterns rather than the individual behaviors within society, what we now call structural inequality, and it is what drives the social determinants of health. I'm a public sociologist informed by philosophy, armed with the skills, the knowledge, and the ability, and now the colleagues, to respond to what has been described as the systemic crises, economic, environmental, health, racial, and political, that continue to fuel each other and lay bare the effects of structural inequality. I am here today, this Martin Luther King Jr. Day. This is actually his birthday, the 15th of January, this day in particular. And I'm here to raise the question about what does bioethics owe social justice? And in a word, plenty. So let's get started. As you may have wondered, I often do when I think about this, from listening to the story of I am from, why I didn't become a lawyer like so many in my family. Their historical and legendary accomplishments, books have been written about, and family discussions have occurred. It wasn't in the cards. I came to bioethics quite by accident, and that's an entirely different talk. You'd have to buy me a drink. Yet it was a happy accident. I soon realized in my beginnings in bioethics that the issues of justice and social justice that had been characteristic of my family's history were deeply, deeply rooted in bioethics, and more so in the issues of unequal or inequitable outcomes in health and healthcare. If your zip code could predict your health, then all the work to achieve equality had yet to secure the fundamental rights to life, liberty, and the pursuit of happiness. And at least to me, bioethics was a space and a place to understand, investigate, and address such wrongs. I'm working at an idea here, and you all are the first to hear what's been rattling around in my mind and taking up space and begging to come to light. I often will think about a talk, or more recently as a teacher, I was an assistant professor at University of Texas at Austin. My classroom was a place where I would sometimes work out ideas. There might be a lesson, there's Tuesday, Thursday, there's a lesson. And I would drive in listening to NPR, and suddenly, ripped from the headlines, there would be a topic that we would have to address. So here, in today's space, there was no pre-reading, just pre-living that was required to come here, okay? To bring your own experiences and thoughts to this place. So this idea had me set out pen to paper, or more specifically, my hands to the keyboard, pulled a book off the shelf, asked Dr. Google to find me a couple of key references, and now I'm here to share with you my ideas for you to hear and enter into discussion with me and with each other. So the purpose of this talk is to spark a connection between the idea of liberty and its relationship to health and social justice. I've been struck by the idea of liberty, the right that we have to pursue being, the right that we have to pursue just being. Oh, are we good? Okay, I wasn't sure if something had happened on the Zoom. So let me say this again. The purpose of the talk is to spark a connection between the idea of liberty and its relationship to health and social justice. Now, I've been struck by the idea of liberty, the right that we have to pursue being, and the limits to government powers in our pursuit of that being. Let us not confuse liberty with your or mine or our individual freedoms about how we do, what we take, what we don't take. We think about liberty as a fundamental right to life, liberty, and the pursuit of happiness, and the kind of balance that we, the people, and the government, we, the people, have constructed to achieve just the right amount of balance. It's like Goldilocks. Not too much, not too little, a balance that is just right so as to neither interfere with nor turn a blind eye to the people's quest for liberty, for life, and the pursuit of happiness. Given this line of reasoning and discussion, I have at times been referred to as a political economist. And to me, it's not a bad thing. I understand and explore social problems as public issues rather than personal troubles. As such, public issues are rooted in the ideas, the institutions, the organizations, and laws that govern and regulate society. At times we've gotten this regulation, this management of society very right. And at other times we've gotten this very, very wrong. Take, for example, slavery. Slavery was legal, morally reprehensible, as in very, very bad people it's a moral assessment, it was bad, but yet ethically permissible. The action itself was allowed. What other examples do you have that represent such rights and wrongs when you think about the law?
What was in the rights?
Pardon me?
I was in the rights.
All in the civil rights, I didn't. Housing,
Yes.
okay, as a Black, as something that we haven't gotten quite right because we redlined and we legally allowed housing to be segregated. What other examples? Right, good or bad, right or wrong? The action is that action of right or wrong about something we value as being good or bad. Another good or bad example. Yes?
That anybody should be hungry in this country.
Okay, that people go hungry. We still haven't, we find that morally reprehensible, yet we haven't acted in a way to minimize or eliminate. What have they gotten good? You know, women got the right to vote. Civil rights law was passed. It's that balance, right? It's a certain kind of balance that we seek to achieve. But when it goes off, it is we, the people, that respond to the underlying values. And in this case today, we're talking about the values of health and health care. So when I use those two words, I'm talking about health. When I say, how's your health today? Right? How are you feeling? You feeling good? You're all right? How's your health? Your health care is that kind of delivery, right? How is your care delivered? Do you have access to it? Can you afford it? Do they understand you when you go there? So when we talk about access to health and health care, they're two related paths to get us there. So in thinking about that, we've gotten this regulation, this management of society as we, the people, okay? Very right, and as I said at other times, very wrong. Such injustice is what the law ultimately steps in to address, okay? The injustices that we, the people, ultimately say no more. The law steps in to make a change to what it had formerly regulated. So when we talk about such corrections to make a more just, fair, equitable society, a more socially just society, one where the burdens and benefits of life do not overly burden, how do we accomplish this when the health and well-being of our communities, of the society in which we live, is defined by the zip code where you live? How is that just? How is that fair? How is that equitable that our zip code can actually be the defining description of how well we're going to do in the longevity of our lives? Next. Let me stop for a second. I have this slide up here for a moment. As you see, has anybody seen this quote before? Yeah, it's pretty familiar, okay? Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. So the Tay's talk talks about getting King's words right. This is an incomplete statement. This is not fully what he said. So let me start with this. So we've come here today to honor the life and legacy of Dr. Martin Luther King. So I begin with this quote. And it's not complete. It's an important and is still as relevant today as it was when he wrote it in his speech addressed to the Medical Committee on Human Rights in 1966. Can you advance it? This was the piece of the sentence that was missing. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane because it often results in physical death. That's the piece that was omitted by my colleague Charlene Gallenrow, because of her curiosity, wondered about this statement, found some inconsistencies, and went on a hunt to find out what was the context and what was really written? What did he really say? And that's where I'm going to spend just a couple of minutes before we start talking as a group. So, this is her article. I want to read a couple of things for it. It is so important to our discussion today. So on March 25th, 1966 in Chicago, a press conference before his speech at the Second Convention of the Medical Committee on Human Rights, King said in part, 3 sentences. We're concerned about the constant use of federal funds to support the most notorious expression of segregation. Of all the forms of inequity, injustice in health is the most shocking and most inhumane because it often results in physical death. I see no alternative to direct action and creative nonviolence to raise the consciousness of the nation. Those are the 3 things that we're going to take apart a little bit while we're here, while I'm talking to you, and maybe explore some more. So what Charlene writes, she takes apart each of these 3 sentences. So we're concerned with the constant use of federal funds. At that time, what King was referring to was something called the Hill-Burton Act. The Hill-Burton Act had been passed by Truman in 1946 as a way to expand hospitals within the North and the South into communities and areas where they were needed and where they could be sustained. But Hill, who was one of the co-signers of the bill, who was from the South, put a clause in that bill in 1946. It had included a Jim Crow provision written by one of the bill's key sponsors, Senator Lester Hill of Alabama, that permitted the equitable provision of services in cases where separate hospital facilities are provided for separate population groups. So when we talk about structural inequality, we're really chasing down what are the laws that are passed that create the organizations and institutions that we interact with. Mostly the organizations. Organizations are much more formal in their construction, right? An organization has a set of bylaws, it has some governing policies, it might even be in response to legislation, where an institution like a church or the institution of marriage are these more socially constructed things, right? But organizations come together to foster and promote something in particular. So the idea of expanding hospitals was a really good thing. People needed them. But Hill was like, we need separate but equal. That was 1946. So 20 years later, King is still responding to this separate, allegedly equal, what we know is unequal, when he's speaking to the committee in 1966. This kind of structural inequality he is speaking out against. It's important to note this little factoid, and this is like a whole other talk that I was gonna do, and I was like, nah, this is like too classroom. But it's interesting to understand the context of how things happen. So this is 1946, when the Hill-Burton Act is written. At the same time, Truman is outraged at the public lynchings that are happening to World War II, Black World War II veterans who are returning home. And there's one in particular in 1946 that particularly catches his attention. A returning Black man who was pulled off of the bus. He was in his full military uniform, pulled off the bus and actually beaten by the chief of police in a southern town and lost his eyesight. So that was gripping news, and that was by December of 1946, Truman had pulled together a committee to investigate the inequalities and the racism that was occurring in the country, North and South. So he has in his mind, he understands that there's something fundamentally wrong going on. And he passes the federal legislation for the Hill-Burton Act, knowing what Hill said. So when they talk about, well, this is my commentary, we talk about politics as strange bedfellows, how we get things done. It is very clear in my reading of it that sometimes we turn a blind eye, perhaps for the greater good. So he has this commission, and that's a whole nother conversation. It's really fascinating. They created a document called To Secure These Rights. And that publication to secure these rights was the backbone for Truman desegregating the military and stood in as the structural architecture leading up to the civil rights laws that were written in '64. So this piece of work to secure these rights is fundamental to the next 20 years. So we have these competing ideas of integration, segregation, liberty, freedom, the right to choose, coalescing all at the same time, to which we're still in conversation about today. So I wanted to set that context for you to think about what was going on then, what was going on in '66, and what we're still talking about today. So, with that said, we want to look at the second sentence, okay? Of all forms of inequality, injustice in health is the most shocking and the most inhumane because it often results in physical death. Domino goes on to say here, this sentence of King's represents his unfailing attention to poverty, racism, education, and housing, what we now call the social determinants of health. There's these structural things that are the laws that create barriers and access in or not into these fundamental housing, health, clean air, the things that we often take for granted. This has always been at the corner, the center of King's work, that we now come to understand drive the social determinants of health. When I said your zip code can predict your longevity, that is a social determinant of health. Where you live, where you play, where you pray, where you worship, where you're educated, shape your outcomes still. So the statement makes clear his moral concern beyond healthcare alone. Secondly, King said that injustice in health is inhuman, not inhumane. The distinction here is likely significant as a matter of degree. Inhuman suggests the lack of compassion for human suffering, whereas inhuman is more extreme, suggesting a denial of humanity so egregiously cruel that it is or should be beyond human action. So these words have strong meaning. And lastly, death. Death is one of the most brutal consequences of racialized injustice. Is erased from King's words by the exclusion of the phrase. So that last sentence, there's just 3 sentences that we were examining. So the last one says, I see no alternative, said King, to direct action in creative nonviolence to raise the consciousness of the nation. Given this context, King's statement seems to affirm the conference's efforts at contributions to raising the nation's moral conscience. In other words, to bettering the country's collective sense of right and wrong regarding health justice. And it is the action that we're searching for. How do we change this moral construct? What is good and bad? Access to health. What is the action that's needed? So let me close out this part of the presentation to you by saying this. Shirley ends her paper by saying the following. The ubiquity of King's words, in whichever form, reflects not only their rhetorical power, but also King's abiding moral authority. The 21st century legacy of King's gift of these words is what we have a social responsibility to raise the consciousness of the nation so as to end shocking and inhuman injustice. And to this I add, this is what bioethics owes social justice, to be the voice, to bear witness to and develop action for calling out and responding to such shocking and inhuman injustice in health and healthcare. So this is my colleague, Charlene. If you have your phone, you can look at that code and find the actual article that I'm referencing. I just want to tell you a little bit about her because it is the inspiration for the talk. She's a lecturer on global health and social medicine, a part-time lecturer in the Masters of Science Bioethics program at Harvard University, and an associate professor emerita at Wellesley College, Women's and Gender Studies Department. Her research explores the ethics of U.S. healthcare, public health, and health policy, and takes seriously intersecting social relations, including gender and race. I want to thank her for her curiosity and her scholarship in getting King's words right. And thank you for listening to what I had to bring to you today. Thank you. So what I wanted to do was just be in conversation. Sure.
It's certainly arguable, and I would agree that healthcare is the most shocking and inhumane form of inequality. But I think if King were with us, he might see it a little bit as well. He might see health as one component of public sector, of what's happening in the public sector in this country for the last 50 years, which is essentially a starvation of the public sector, which includes education, housing, transportation, health. And what we've seen, what we're really living through in this country is a kind of an experiment in the reduction, starvation of all public sector activities. Healthcare certainly maybe in some ways the most vivid, but it's not. But the reduction of resources to housing, transportation, and education are equally lethal. But it's part of an overall pattern because it's a political agenda that accelerated with the election of Reagan in 1980.
It is a political construction. I often think of it as the promotion of the scarcity concept, right? If we really think that these things of housing, clean air, water, as scarce resources that we have to fight over, we put each other in competition with one another for these goods. These goods ought to be the social goods that we are all entitled to as a basis, just a basic fundamental way to get started. How we use them, how we take advantage of them ought to be a personal choice, not something that's prescribed by society or its laws or its beliefs about the other, whoever that might be. Any of us could be the other, due to our gender, due to our age, due to our social position in society. We could find ourselves on the other end of being the other. And if that continues, we will constantly be in peril.
Yeah, I was wondering if you could just give concrete examples of like for instance, the lack of health care. So people living in poorer areas of the city. So what's the difference between that and living in a more affluent area? Concrete example.
It has less to do, in one measure, about literally where you live. I did say zip code is very important in this particular way. It's not the fundamental thing. There's something that happens more strategically about why there's such a difference. If you live in the city, what city do you live in? What side of town do you live on in that city? Okay, if you live in a rural space, that might be fine. That's where your farm is. That's where your family life has been. There ought not be these grand differences. So let me try and answer you with a concrete example of the ideas that get inculcated in people's beliefs, their policies, and potentially the laws that follow. So a few years ago, I was on a panel at my work with some very esteemed colleagues, some very, very smart, esteemed colleagues, and we were talking. And one of them, a social determinants of health question, similar to what you had asked, got asked in the room. And it was about the opioid crisis. And at that time, this is probably like 2016 or 2017. And what we were seeing then was mortality rates in middle-aged white men for the first time were declining, and it was directly linked to the opioid crisis. That for the first time in almost 100 years, decline in mortality among this population. So my very esteemed colleague sitting to, I think he was to my right, was asked a question. I don't remember the prompt, but the answer was, yes, you know, this mortality thing is real, but isn't it a good fortune, and now I paraphrase, but isn't it a good fortune that Black people didn't get caught up in that and realize that as a reason for mortality? Now, that was pretty shocking to me, because when you unpack that statement, it tells you a couple of things. Black folks' pain was not being attended to during this crisis. Okay? They were not being, unfortunately, like what everybody else was experiencing, being overprescribed a highly addictive drug. Some folks' pain was being attended to as a downstream terrible consequence of a highly addictive drug causing this very negative outcome. But at least Black folks were saved from that. And I'm like, oh my God, this is an absolutely horrible idea that permeates this, that leads to these differences that we see in mortality. If pain is one example of mortality, you look at women's health and you look at the outcomes of maternal fetal outcomes in Black and brown women. And you talk about pain, and you talk about the perception of pain, and you talk about the underlying and explore the underlying social misconstruction of, oh, Black people don't feel pain the same way, Black skin is thicker than white skin, a whole host of things that are born out of slavery to justify slavery that carry forward literally in the air that we breathe, in the medical system to which our young people are trained, regardless of their color. Okay, this is a training issue. This is a set of thoughts and beliefs that permeate and that don't get responded to. That when you look downstream and wonder what's going on, you have to look back up to find out what these ideas are being, what is being promoted, what is not being addressed, and how does it relate to the outcomes that we're looking at. So trying to unpack that in a very hierarchical environment. Medicine is very hierarchical. They often compare it to the military, but I'm like, yeah, you guys don't know what military life really is. You're talking about like, and no shade to my pilot friends at American Airlines or anything like that. But when you come out of a military training for flight, it's a very different hierarchy. Okay, that's where medicine needs to be
Can
compared.
anybody in America, now, I don't know, let's just say here in the Northeast,
Mhm.
in New York State, can anybody, regardless of where you live, do they have access to a primary health physician that you go to 6 months?
No. What is, so no, flat out no. Why no? Well,
Well, is it Medicare, Medicaid?
no, so let's think about it. Those are really important questions to unpack. So when we first think about access to health care, right, like going to the doctor, what is that founded in? How do we get our health care card? Work,
Yes, sir.
through work,
Insurance.
through work. Through work, I get insurance because I am employed in the kind of job with the right number of people in the organization that are mandated to provide medical insurance.
Yes.
Okay? Full-time. I could be a full-time employee working 3 jobs that add up to 40, 50 hours, but still not have insurance because I'm not at an organization. Now, shout out to UT Austin, because even our graduate students who work 20 hours get full insurance. When I had my GRAs, they were expensive because on my grant, I had to pay their insurance. So that's a good move at 20 hours. But at 19, they didn't. So work is the first avenue, a certain kind of work. That work has to last a certain duration. So at 62, okay, I can qualify for Medicare. We care for the elderly, and we aid Medicaid, we aid the poor. So work is the fundamental driver of insurance. So there's a range of folks where that doesn't work. Now you can be independently employed, okay? I'm a mogul, okay? I've created my own business. Money is not important to me. I can go buy my Blue Cross Blue Shield at $1,000 a month, and insure myself, and at $1,500 insure my family. Okay, that's one way. Insurance is available. But when you're caught between there's a differential for Medicaid to jump in, okay? How poor is poor? Where's the gap? And then how much money do you have to be making to be able to afford something from the Affordable Health Care Plan's options? I always had a range of students who were independent, living independent of their parents, who were paid just enough money above poverty, which is somewhere around, $10,000, $11,000 a year. Okay, who made just enough, but not enough to qualify, who had no insurance.
So if you don't have insurance, let's say you get diagnosed with high blood pressure. How do you get, so if you can't see a doctor and monitor
What you have
your
options,
medication?
what you have options for when you're underinsured or uninsured. So underinsured might be, I have a premium, and I have to pay $6,000 or $7,000 before the copay, of $35 kicks in. Like I gotta pay the full price, right? If I don't have access, I can go to federally qualified health centers that are underwritten, that will see and underinsured folks. The wait time can be a while, several months before I can be seen. If I am prescribed medicine, I will have to pay out of pocket. So let me just share with you something. I used to serve as a bioethicist, a clinical ethicist at a 900-bed hospital in Washington, D.C. And I saw a lot of ethics cases. One of them that stands out that's very familiar to the question that you're asking about, how do you get insurance? There was a young woman who was one of our case consults who had a baby. She was readmitted to the hospital, maybe 26, something like that, who had a stroke, a devastating stroke after giving birth to this baby. And upon looking through the records and trying to understand what happened, it turned out she couldn't afford her hypertension medicine to take it daily. So she was taking half the dose. And half the dose wasn't sufficient to control her hypertension, and she had a stroke. So the insurance is a vital thing. You have to find the right clinic. You have to find the right resources to find a place that will underwrite your medication, and to get that medication to last 30 days. We know about the conversations about what is the EpiPen costs went up, we had to regulate that. The cost of insulin for people who live with diabetes had to be controlled because it was getting out of control. These are the crises of health. How is your health today? How are you doing? Did you take your hypertension medicine? Can you take it daily? Okay, and access to health care in a society, in a structure, okay, of economic structure of capitalism that we live in. Capitalism is a very interesting way to make money. Its object is to make money. It raises questions about, is it sustainable with some of these consequences that we're talking about today as it relates to health and access to insurance through your job or in the open market, and how do you do these things? Are there better ways to pursue and have access to the liberty of just being? Not the freedom to choose. I'm not regulating how you choose. That's your right. You get to choose which way you want to be. But I want us to think about the idea of just being. Okay, given the constraints that we work in, there's a question in the back.
No, I just wanted to say that I really appreciate the way that you steered this back towards the idea, getting King's words right. I think when we're talking about, this is just a personal feeling, the gap between his quotes being taken out of context or truncated, a lot of the time what we find is that the challenge to society is the part that's omitted.
Yes.
So you're left with the platitude, but not the task. And so what ends up happening, even in this, the way this conversation has gone, you were talking about some of the systemic beliefs that we have held, right, regarding African Americans within this context of society that would lead to the conditions that would cause folks to have less insurance or less access to healthcare, thereby having less access to general health. And it's because of what we believe about our being.
Yes, yes,
right?
yes.
And so we, in the same way that we can cut King's quotes off in a way that makes everybody feel okay or at least feel less heavy,
Mhm.
we can talk about the logistics of the differences between how, insurance through work, Medicare versus Medicaid. We can talk about these logistical differences while ignoring the work that would have to be done systemically for each of us to believe that we're all sort of equal.
That we have,
The same amount of humanity.
yeah, we have this right to this minimum necessary to thrive, to get there and to thrive. Ma'am, I saw your hand. Thank you so much.
Yeah, I just wanted to sort of layer on something to the complexity of this. Access is one level. That's how do you pay for what you get? But the next question is, what's the quality of what you get? Because the disparity of quality available between going to a federal clinic versus, or a state clinic versus going to an academic medical center is material. And that spectrum really, again, the disparities are enormous.
They're huge and they're real. And it is what begins to shape when we say your longevity is tied to your zip code. Okay, to where you physically live and what your access and the quality of that and how you change the academic medical center apparatus is beyond me in one way. I do think that as someone who's taught for years, I've taught at the baccalaureate level, I've spent a lot of time at the graduate level, which we would call medical school, and at the professional level, teaching residents and attendings about biomedical ethics. I do see a bit of a change in what we are requiring baccalaureate students to know to apply to medical school. There is a little more emphasis on bioethics. But unfortunately, for like all my young people that I deal with, they can learn it in a book and they don't have to take my class, right? They don't have to take Nancy's class. They don't have to take, a whole lot of my friends' classes that teach programs. They can just read a book and answer some questions. But it's an attempt. The American Medical Association, AAMC, American Academic Medical
AAMC, American
Association of Medical Colleges, changed their requirements in 2015 to say that you had to have this sort of social and behavioral understanding. They could go further. I'm going to try and ask them to go further and be clear about that, because that's what begins to shape the quality. Medicine is an arduous undertaking. It was 4 years in 1910 when the first report came out and said, this is how we're going to standardize medicine. It's still 4 years in 2024. There's a lot of things that have changed in a little over 100 years, but the shaping of the medicine is still 4 years. So it's really hard to figure out, like, how do you put this into that? I say you put it into the baccalaureate experience and help shape that to become the next generation of physicians who are attempting to be aware of these social constructions and how it has fed in to the way medicine has been taught and constructed. So
you see the inequalities in medical care mainly in racial terms or in social class terms?
Race is often a proxy for class, but often, but not always. Even in the studies where you control for socioeconomic level, okay, being black can still be deleterious and bad outcome. Okay, so despite the fact that you are well insured, you know, you read 3 languages, you know, so on and so forth, bad outcomes can still happen. So the social construction part of your question is an inability, an inability, an unwillingness to talk frankly about race and racism. There is a fear that too many of my colleagues, and I would say that, you know, like I put everybody, you know, like you're black or you're white, like whatever side of the house you fall into, you're one or the other. To really talk about, wow, that seemed really kind of racist or like really one-sided or really wrong. I don't know why, but that was really wrong what you said. And we're not very good at that. We're not very good at calling out wrongness. Okay? I mean, I can give you like 100,000 different examples in my existence. Some as simple as, you know, remember when the world where everything was all on Zoom, you know, and everything, my entire life was on Zoom. Our teaching was on Zoom, our faculty meetings were on Zoom, and even this workshop for, you know, equity was on Zoom, and it was later in the afternoon, taking a break, but, you know, a hot mic situation occurred while we were waiting for the diversity, equity, and inclusion officer to come talk to us. So we're waiting, taking a few minutes, and somebody's on camera, and you know how Zoom always goes to the picture of the person who's talking, right? So his camera wasn't off. His camera was on, and off mic over here, someone says to him, hey, what's the next section about? And he turns to look this way or whatever, and he says, you know, it's that DEI stuff. And I'm like, oh my God, like, where's my phone? So I'm like texting to one of my colleagues, like, oh my God, you know, and the guy who's gonna talk is a DEI officer. And I'm like, oh my God. And I wasn't fast enough on my feet when the DEI guy came on, who's a colleague of mine, to say, hey, that was a really interesting demonstration of a passive-aggressive statement. You know, like as though they had maybe staged it in a positive way. Like nobody said Jackson. Like I didn't say anything, my good friend didn't say anything, we were all like mortified, and we're talking on it on the back channel, like, oh my God, oh my God, oh my God. Okay, but none of us in that moment can figure out what to do. And there's plenty of moments like that. So when you say the social, ask about the, you know, what's a proxy for what and what's really going on. We're socially, I feel, very uncomfortable to talk about those things amongst ourselves and in larger settings. And I appreciate the space here today to be asked to come and share with you, basically a complete stranger, you know, from a well-known place, but basically a complete stranger, to share with Austin some of my writings and ideas and that of my colleagues about how we think about the consequences of inequality, and that not being afraid of saying, I don't understand, or that's, you know, you don't need to defend me. If you think someone said something, well, I can tell you another story, but if you think somebody has said something to me that is disrespectful in some form, I can take care of myself. But if you were offended, you need to turn to the person and say, wow, Joe, Fred, Carol, I was kind of uncomfortable by what you just said. It didn't feel, it felt wrong, it felt, I don't know what you meant. you know, to be able to talk about it. We don't have to name the injustice of the moment, okay? We don't have to know all the academic terms that I could regale you with. Unimportant. To know, that was just wrong. That was just wrong. We need to know. Yes, sir.
So, you know, I live here, exclusive white zip code, and I kind of want to ask you about your attitudes and you know, how much do you think it's a matter of deliberate exclusion versus, like, structural inequality doesn't happen by accident. There's a reason why it's structural. And like the first exposures I had to the zip code thing, I worked in politics in the 1980s. In the 1990s, there was the Open Secrets campaign, and you learned that most of the political donations came from a few rich white zip codes. So, okay. And then in the 2000s, you know, I ran across research on adverse childhood. So you found out that kids who grew up in bad housing, bad neighborhoods, like pain, you know, their later life outcomes were predicted. That was racist too. And then, you know, I did work in housing, and there I know that it's true. There, it's a matter of deliberate exclusion, particularly of Black people. There were restrictive covenants, and there was redlining, and all that stuff was embedded in Redfin and, you know, the appraisal software and so forth. So that those deliberate choices to exclude Black people get embedded in markets themselves. You can say, well, you know, people, any of us could be othered by age or by gender. We could be on the wrong side of that equation. And it's just a flaw in the system. But it did start out as a flaw in the system. It started out as deliberate exclusion. And what I wanted to say, first of all, I'm white, I live here, I kind of don't have a right to an opinion. I want to find out what you think.
You do have a right to.
I have an opinion about it, whether I have a right or not. But when I was working on these programs, you know, the idea of bringing the dream home was not just that, you know, we have to get it or it needs to be more than performative. The idea was that, you know, race as a social determinant was the key factor in this part of the world in our time of life, you know, not in the South, not during the Civil Rights era, et cetera. So, and when I would talk to white journalists about what we were doing, they were like, well, that's historic, you know, there was deliberate exclusion in this area, there was Klan activity or whatever. You need to write about that. Or there are undocumented immigrants whose rights are being violated. We need to write about that. When I would talk to Black journalists, they were like, yeah, of course.
Sure.
The town I grew up in had the same issue. You know, why are you telling me about it?
Surprise, surprise.
Right. So I want to know what you think about the deliberate exclusion aspect of structural inequality and how this applies to.
How it applies to public health?
Yeah, because in your research.
So let me say this about that. I want to say the name Ruha Benjamin. Looking at some of the AI, the artificial intelligence work, and saying that the idea of turning to artificial intelligence is a way to remove bias in the system, right? Let the system, you know, the algorithms, okay, the algorithm of oppression is the title of that. Let the algorithm figure out what the right distribution pattern is. Algorithms are not sentient things. They are created by people. They're people like us with the beliefs and the experiences and the exposures that we all have that create these outcomes until we as human beings, Black or white, and again, I use the whole world to fall into one of those two categories. Okay, you're either in or you're out. Until we come to terms with our own individual biases, I have mine, I wrestle with them on a daily basis. I try to be aware of them. I try to set them over here, but understand how they influence me. Until we're able to talk about that amongst ourselves, okay, and acknowledge that this was a country that was founded on the idea of liberty and freedom for some. Some were not women, okay? They were men, they were white men of a gentry class, who owned land, and maybe some of the guys who worked the land, okay? But it wasn't written for most of us, okay? And And if we got too old, it wasn't written for most of us. And if we look at the downstream codification in the law of how laws got structured to allow redlining to be a de facto experience and then often codified in the law, to allow the GI Bill to only go to 1% of Black veterans who came out of World War II, who laid their life on the line for this country, to be educated, to get homes, to do the fundamental things that create multi-generational wealth, that allow you to take advantage of what capitalism does deliver, that promise, if you can get into the stream. We have a long way to go if we can't talk about it, if we can't recognize it. I left a state in August that said, January 1st, diversity, equity, and inclusion policies could no longer exist. My colleague who I still work with was asked to scrub some of his website because the language on there was deemed unacceptable. I asked the guy that I taught for, my director, this is the first time in my entire career that I am relieved. Teaching's hard, but then I'm relieved to not have to teach because I was afraid of being reported to the dean. Because I do talk about Marxism. I talk about the fundamental social constructions of the bureaucracies that are created. There's Weber, there's Hegel, there's Marx. We talk about the structure of society. You know, what are these theoretical components? And they're fundamental. They're just like fundamental stuff that you teach. You go like, here's the fundamentals, and then they went 97,000 different ways. But this is where it all came from, right? I was afraid to talk about that. Because if I offended somebody in my class, I could be asked to immediately step down, become investigated. If I lose, I would have been banned from the UT system for life. And as a Black woman, that scared the crap out of me. And I wasn't sure, and I didn't have to figure out how to teach. And I was relieved. So I it doesn't really answer your question, it just makes the dilemma larger. And more real. It's like real, it's like really, really real.
As you've been talking, it's kind of gone back to some of your earlier theories or concepts that you were laying out when you talked about, we the people, pursuit of life, liberty, happiness, and then applying Dr. King's philosophy and words to those things. And it's all been making me think we need to start with just who are we talking about when we say we the people? We're not even getting that.
You're not getting that right.
It should be all the people.
Y'all.
And we also had discussed earlier about life. What are we defining as the life that all of the we the people should have? And that is supposed to be, earlier we said, it's not supposed to be a crap life. It's supposed to be a healthy, fully imagined, safe life. And that should be for all. And it should be the we the people, and that should be all the people.
Yes.
And it's almost like you have to go back to that conversation.
Yeah, and in putting this talk together, I did go back, I reread parts of the Constitution to remind myself of what this, as they say, this great experiment is, it continues to be. And in sociology, we talked about this Hegelian shift, right? Hegel talked about his work as being a thesis and the antithesis, right? An action happens, it swings us in one direction. There's a reaction to that direction, it swings us in another. And at some point, it comes back. That synthesis of these two opposing ideas comes back as synthesis, right? Of what turns out to be, left and right, literally and figuratively, that it synthesizes into something else. And we are in that moment, we are living that moment of an action and a reaction. We're in the reaction side, and we're going, wow. Many of us are going, wow. What is this? What am I looking at? What are these things that are happening? And how does this resolve? It is through the foundation of what is democracy. And this isn't supposed to be, I'm not here to do a political talk, right? But I am a student of history. And we must be students of history. This is not new. This moment that we are in is not new. We can go back a couple of generations and see this very moment. And the fear that people in society have about the lack and the limitation and their futures, and their future children, and their health and well-being are fueling us again to be in opposition with one another. It is not new. Go back, read securities rights. Take a look at what was being understood there. And think about what it is that we, the people, have been given to do. Thank you.
Thank you so much, Virginia.
My pleasure. Thank you.
My gosh, there's so much to think about. But can I just say that I think we're all very pleased that you're here, Beacon and Garrison, and that we won't be saying goodbye to you, we'll be saying, when can you come back? And let's talk some more.
Of course, my pleasure.